So welcome everyone. My name is Susan Bankowski. Hi everybody. So today I'm talking about, I'm the chair of the IRBs for the oversight of human subject research here at OHSU, and I'm talking about the ethical oversight of human subjects research. I direct the IRBs and I also direct the research ethics program here. So I wanted to start a little bit with some background about why it is that we have the current protections that we follow currently for human subjects research. The Nuremberg Code exists as an international code from a judicial decree out of the trials that occurred in World War II with the Nazi physicians in the concentration camps. And the big elements that came out of this were that there would be, of course, since these were prisoner populations, there was no consent involved. And understanding that there has to be a requirement for voluntary consent and that there has to be an assessment of risk and benefit. With these trials, they were looking to see how to have better ways to serve their soldier population and how to have better ways to treat prisoners, not in the good sense. And so this really didn't have a risk-benefit assessment at all. So those were the main things that came out of the Nuremberg Code. Then the World Medical Association came out with the Declaration of Helsinki, the first time being in 1964. It gets updated fairly frequently, so the last incarnation is from 2008. And this was a group of physician scientists who then have created a national code that we follow for the ethical conduct of human subject research. This brought in concepts of written informed consent, also appropriate scientific background, prior animal trials for when you conduct research. Many may be familiar with the Public Health Service's Tuskegee syphilis study. And so this was here in the United States. It was a public health trial initially that was funded by the government to look at the natural progression of syphilis in the population of black men in southern United States. And while this was a good idea from a public health perspective when it started, mid-study it was discovered that you can treat syphilis with penicillin. And so the population who didn't quite understand and they didn't initially even obtain consent in a meaningful way from that population to start the natural progression study, then was kept uninformed about the fact that they could receive treatment. And so you could imagine that since this is a communicable disease, not only was that population at risk, but then also many of their contacts. And so this went on actually for 40 years, and there was an expose that occurred with respect to a New England Journal of Medicine article that examined what was going on and kind of brought this forward. At the same time, there were some studies going on at the Willowbrook Hospital for retarded children, as it was called at the time, in New York, and this was exposing them to hepatitis when it was expected that they would get hepatitis, and so facilitating the research in a way that wasn't fully consented with the parents. And so with all of these activities that have gone on over the past century, then in the mid-70s, as these things came to light and kind of culminated, they really felt that it was time, in light of the Tuskegee trials, to have a government look at what's going on. And so a group gathered at the Belmont Center in Maryland, and they were to consider what is it that we should be thinking of for the ethical conduct of human subject research. And out of that, in 1979 came the Belmont Report. And this is really, this is a great document. I read it every year when I teach coursework. And it sets out what are the ethical principles, the three ethical principles for the oversight of human subject research. And I'm going to touch upon those for you. From that then comes what we call the law for human subject research here in the United States, and that was to codify the principles in the Belmont Report. And then finally, as I said, the National Commission came out with the Belmont Report, and for years then, human subject research was conducted in the framework that was created at that time, and as science progressed, some events happened, which I'm going to talk about, that had us have some shutdowns of institutions in the 90s, where it was that science is such now that maybe the way we envisioned things in the 70s hasn't evolved, and we need to think about how we have oversight for human subject research. And so,
you mean that they stopped universities from conducting research?
They did. So there was a time in the 90s where some major institutions, University of Pennsylvania, Johns Hopkins, and Duke, were had their research put on hold because the government was worried about the way that it was being conducted. And then at that point, there was a real shift in kind of building up even more so from the look in the 70s and 80s to now. You know, what is it that is the best way to have oversight for modern scientific research? Great question. Okay, so the Belmont Report, I talked about this. So the Belmont Report has 3 duties that an investigator should have with respect to their research subjects. And it's important to think about when you look at the duties for research, when you think of a physician and the care that they give, this is to do no harm to the patient, that you're trying to cure them and do no harm. In research, it's a dual commitment where although you're working in the best interests of the participant, you also have to understand that you're trying to answer a research question, and so you've got also a commitment to the science, and those have to be balanced. And so in that, you need to have a respect for autonomy, that the person can decide on their own to voluntarily participate in the research. Concepts of beneficence, where that you're really wanting to maximize benefits, and this is what I'm talking about, and minimizing harms. And then justice, making sure that you are distributing the burdens fairly, that you're selecting the appropriate populations in which to study, that you're not taking advantage of vulnerable populations. So I'm saying the IRB, this stands for Institutional Review Board. They are the groups that have the mandate for the ethical oversight of human subject research. We are tasked with reviewing research involving human subjects. Here in my IRB, performed here at OHSU by our faculty, our research staff, and our students. We protect the rights of and the welfare of the people who volunteer in our research studies. And then we protect, along with that, the confidentiality protections if it's protected health information. What is not known by many is that there's no universal law for the protection of human subjects in research. So I talked about the international codes, and while they're persuasive, here in our country, we don't have a law that applies to any human subject research. And so, in fact, it flows from the way that we're funded. And here at OHSU and in many research institutions, we've received federal dollars to conduct research, and so we have an FWA, a promise that we've made to the federal government that will follow the laws for human subject research. It's called the Common Rule because there's many different agencies that fund research, and all of them agreed that they're going to follow this system. You'll also see, too, that the FDA has their own regulations if you're studying a regulated FDA product. And so just as I explained, this is tied to funding. And once you engage your institution or in collaborative research, if you have community partners you're working with and it's a study that has multiple individuals involved, then once those individuals are also engaged, then that's when you have this requirement of having a federal-wide assurance cover that commitment. Here at OHSU, we apply the standard to all research regardless of funding source. So then what is a human subject? It seems simple, but in fact, it doesn't end up being that simple. One thing to know is that, and we've got a definition that we work with, it's a living individual about whom an investigator, and whether that's a professional or a student, so these cover students as well, is conducting research by obtaining data through intervention or interaction with that person, or identifiable private information. So an intervention is an easy thing to think about. You know, I'm coming to you and I'm taking blood or giving you a drug. Interactions, sometimes people miss that one in the sense that, you know, it could be that you're having a survey or something, interacting with them, but it could also be that you're manipulating someone's environment. You know, is it that you've, you know, changed the lighting in their setting, or that you've modified, you know, the exposure to some sort of contaminant in their work setting or something like that. So it may not just be that you're interacting with a person, but also their environment. As far as identifiable private information, you know, what is identifiable includes things, is there a linking system? It's not just you can tell who the person is by looking at the data, but also is there a coding system where someone can tell? And what's considered private oftentimes is considerable. So this is a reasonable person's expectation of privacy. And this is just a little chart for us to think about, if you're having an intervention or interaction, yes, it's human subjects. If not, is there identifiable information? If not, then this isn't human subject research. And generally, it doesn't fall under the laws for protection of human subjects.
But that interaction could be that you're just talking to somebody, correct?
Definitely, it could be. It could be that you are on the corner of the street downtown Portland and surveying people about things. Or it could be that you're studying how it is that people converse with other people, and that may be the interaction. So there are all sorts of things. It's a very broad definition, interaction, for sure. So people ask, well, then what is, if everything's a human subject, what is not? So this does not cover deceased individuals. If you're gathering health information, HIPAA would apply for the deceased, but no others. It could be that it's that there's some existing data, but there have to be a bunch of conditions that are met in order for existing data not to be human subject. That it's data that's already exists at the time of the application. The investigator can't access identifiers, and that there's no link or code. So it could be exempt. We have categories of exemption that exist where it's, it's a low risk study, but that there are certain protections that just need to be minimum. All right, so we've got yes to human subjects, but then it's got to meet a second part of the definition, which is what is research? So research is a systematic investigation, including research development, testing, and evaluation, designed to develop or contribute to generalizable knowledge. And I've included the NIH definition down here as well. What's important to note here is that you've got a plan and that you are going to follow that plan in order to create some sort of information and opinion, evidence-based decision that you think is valuable for others to know. Important to think here, so I have a public health background and I get these questions a lot. Some things are in the gray area. Some things you're not sure if they're going to be research or not. And this is not an easy question to answer, but public health surveillance, quality assessment activities, maybe a case report. And so you really need to think about what the intent is of the activities. And sometimes things are done for a non-research purpose, but at some point during the continuum, they become research. It becomes, you realize that you're onto something good and that you want to share it. But it may be that originally you were funded to do a quality assessment activity by the NIH, and they are expecting that you'll do this activity and share it with others. So it depends on what you're doing.
Let's say we were weighing and measuring children in schools.
Mm-hmm. We have studies that do that, and so it depends.
Just as surveillance for...
So yeah, the act of, if it's something that is done routinely at the schools and is being done there for the purpose of the public health activities perhaps, or that it's something that's required as a school policy, then that wouldn't necessarily be research. But let's say you're looking at instituting a policy that might be weighing 3 times a year versus once a year. Or, does it make a difference if we separate children by gender before we weigh them, or things like that. So, and you're wanting to look at that and then help inform people as to how to have best practices in other schools, then that might be more like research. So issues in research design that the IRB considers, we want to think about the IRB review, what's required for us to conduct our review. I'm going to go over that. If we're getting permission for the potential volunteers, what informed consent would look like. Are we collaborating with anyone? There's a concept called equipoise. If there's 2 arms, do we have an uncertainty between the arms, and that helps us justify the design? Is there a safety monitoring with respect to protecting privacy and safety of individuals in the study? Do we have any special groups that need extra protections? And do we have an investigator that can be compliant with all the requirements in the trial? Okay, so I have a list here. Hope it might be hard to read, but so IRB review considerations. And these are what's written into the law for us. They're the minimum that we consider, but we could consider more. So first we want to look at the design, the proposed. So when anyone creates a study, they put a plan together, and then they submit it to us, and we look at it to try to bring a group of people together and decide if we think that it meets all these standards. So we've got to consider that the risks to the subjects, and we say subjects rather than patients because they are considered volunteers, participants, subjects in a study. They're minimized. That those risks are reasonable in relationship to the benefits. So are they balanced? Can we balance out these concepts and feel like the design is justified? There's equitable selection of participants in the trial. If we're getting appropriate informed consent from them, or perhaps from their legally authorized representative if it's someone who can't consent for themselves. When appropriate, that we've got monitoring provisions for the data collected to ensure safety of the participants. And whether or not the vulnerable populations are adequately protected as well. And so, like I said, safety and confidentiality provisions are monitored throughout studies. I have been mentioning vulnerable populations, and some wonder, what would that mean? We do have written into the regulations certain groups that have been identified specifically as being considered vulnerable in that they may be vulnerable to coercion or undue influence in a trial. And so those are children, prisoners, and fetuses and pregnant women. Individuals who may have a reduced capacity to consent, that should say consent there, the terminally ill, students and employees are others that have been identified as potentially being considered vulnerable. And so any study with vulnerable populations, we want to make sure there's adequate extra provisions to consider their vulnerabilities and protect them. Payment is allowed in research, and you can compensate individuals for their participation, but it's considered compensation for time, perhaps expenses for getting to or from the research site. Sometimes it's even considered payment for their kind of hardship for having to go through the process, but it should be such that it isn't unduly influential. So you don't want a payment to be so high that it would induce a person to do something that otherwise their good judgment would make them not want to select. And so we think about the population who's being recruited, and we look at the payment and think if that's appropriate given considerations of undue influence.
And if when you're reviewing and protecting those human subjects, there's no mention of any compensation for the subjects, does the IRB wonder why?
Not necessarily. If there's no mention of payment, we assume that there is no compensation for participation. And at that point, the IRB would consider whether in the consent form it should be called out that you will not be paid for your time. And depending on the population, that may be an important thing to call out for certain. I've been talking about the informed consent process. You should know that it's a process. A lot of times there's a form involved that is kind of the guide for the process, but you can certainly be innovative in how you work with a potential participant in educating them about participating in the trial. And the goal of the process is to provide them with enough information so that they can choose whether or not this is a good choice for them. And that can come in a lot of ways. What you need to communicate, however, depends. These are the requirements for consent process, and if it's a minimal risk study, some of these can be modified or skipped altogether depending on if you are having an interaction or not with the person. So you want to certainly have a statement that this is research, that the purpose of the research, how long it's going to take, what's involved, what the processes and procedures are, what, if anything, is experimental in nature, if there are any risks or discomforts that are anticipated in your participation. These can include not just physical risks, but it could be, is there something that could be a psychological risk? Could there be a risk to identifiability? If you're studying illegal behaviors, could this affect your ability to interact with the social justice system? So risks can be broad. Benefits, if there are any. Now, it's not a requirement for research that there be benefits, quite honestly, but you do have, it is a requirement that the risk-benefit analysis be balanced and adequate. So, of course, the more risky a study, the more benefit, the potential benefit there needs to be to make that balance. If there are any alternative procedures available to research, what type of confidentiality protections are in place? No exculpatory statements are allowed, so there can't be anything in the consent process that does or appears to limit the participant's ability to seek compensation and to sue if they feel like they've been wronged, to bring suit against the researchers. We just talked about undue influence, the other being coercion. So there can't be coercion. For me, the best way to think about coercion is like the concepts of blackmail. You can, if you're in this study, then you'll get great care. And so, of course, you need to, or you won't get care if you're not in this study, and you can't condition anyone's care or abilities to seek care on participation in research. I always think of undue influence as an offer you can't refuse. That participation is voluntary. And then with some of the greater than minimal risk studies, you need to also consider, explaining where someone can get compensation if they feel they've been injured in research. If you have questions about that compensation, who to talk to. And as I mentioned, that your refusal doesn't put in jeopardy the benefits you receive.
Susan, who can interact with patients to get them to sign the consent form?
Researchers, in the very broad sense of the word. So anybody can, and it depends on your study design, but the individuals who are obtaining consent are considered engaged in research. And so with that comes the responsibilities of being knowledgeable about human subject protections and being captured, and I say that in the way under some sort of an agreement with the government that you are under a program that has follows the principles for the appropriate conduct of human subject research. And that can be done a couple ways. But really it's that, but if you're working with a community group and they'll be obtaining consent, then you think about how it is that we get that group well educated on these concepts so they're obtaining consent in the appropriate way. I've mentioned minimal risk a couple of times. It's a really important concept because we have a few conditioning requirements on this definition. So I'll go over the definition and then let you know how we work with it. So, because like any legal term, it's clear as mud. But the probability and magnitude of harm or discomfort anticipated in the research are not greater in and of themselves than those ordinarily encountered in daily life or during the performance of routine physical or psychological exams or tests. So we call this a normal healthy person standard, being that you are comparing the risks in the research to those that happen to a normal healthy person. This is important because that means that someone who's sick it doesn't justify something more risky to them just because they're sick. That being said, it could be that because they're sick, the risk-benefit analysis is appropriate. It also, for community-based research, means that just because someone lives in a dangerous neighborhood or a neighborhood that might put them at risk, that they also should not be put to more, assume that more risk is appropriate. That being said, thinking about what's minimal risk is a difficult concept. So what you go through during a normal healthy visit at your doctor, first of all, a lot of adults, for better or for worse, don't go to normal healthy visits, but you think of your children, and the most risky thing my kids get is maybe an immunization. My children, healthy children don't even get blood drawn. So I think the more dangerous part of my children's day is on the playground, driving in the car, perhaps going to soccer practice, and so, but that's the risk that we're comparing it to. What is it in your daily life that is risky? And so we use this definition to decide if something needs to be reviewed by a full board, a full committee of the IRB, or if it can have one or two trained professionals of the board conduct the review. If the consent process can be altered at all, so if something is minimal risk, then we can consider whether or not it's appropriate or needed to have all those elements involved. Do we really need to put a signature on paper at this point. Can it be an oral process? Should we use flip charts? You know, there's all sorts of ways to modify a consent process if they're minimal risk. And then the last way we do this is to think about allowable research for children. And I'm going to go over some of the children's considerations and how minimal risk comes into play for that. And that's the next slide. So the children's issues, there's a number of things to consider for research with children. First of all, every study that's conducted needs to fit into an approvable category for child research. And those are 4 categories. And for a working IRB, actually 3, because the first one is minimal risk research. So minimal risk research we can approve. The second one is greater than minimal risk research that has a prospect of direct benefit for the children in the study. And so this making sense, and best examples of these are, you know, clinical treatment trials where it's a sick child seeking care and they're trying out a new treatment. The fourth category is greater than minimal risk research with no prospect of direct benefit for that for the children in the study, but likely to yield generalizable information about their disorder or their condition. So this means then that the children in this trial, if you're going to subject them to the greater than minimal risk activities, they have to be in that class of children that have a disorder or condition. And there's a lot about, you know, what is a condition. I've seen papers written that say adolescence is a condition, so it depends on how you're looking at this. But those are the categories that we are allowed to approve in. If we think a study is a great study that should be done and we feel it meets all of our categories of ethical appropriateness, but it doesn't fit into one of these 3 categories, then we can send it to the government for special review and see if it's something they think should be done. We also think about how to select consent and or assent for children. Assent being a child's asking a child if they agree to participate. So if you have a child enrolling in a study, it's likely that we'll be asking their parents for consent to participate. And we use the distinction being that adults with capacity, you know, it's that we say you become an adult legally by age 18. If you have capacity to provide consent, then children deserve the respect to be considered, to have their considerations worked into this, but it's not consent, instead it's assent. You know, yes, do you also agree to be in this? And I do.
Is there kind of a age where you start to ask the assent?
Yes, our policy, based on some studies that were done about children's capacity to understand questions, starts at 7.
Okay.
You know, that being said, I have children, and I always say that if you ask them, you know, do you want to be in a study where we're going to take your blood? And, you know, they're going to say no. So, you know, it's really that you have to think about kind of the whole process that you work with the parents and the children and the educational process that you go through in a consent and assent. To that question, though, then here in Oregon, and it varies state by state for law, 15 to 18-year-olds can consent for themselves, 15 to 17 actually, can consent for themselves for medical treatment, for seeking reproductive health care, for getting treatment for addictions. And we respect those laws in a research setting as well. And so if the study involves seeking treatment for a research purpose, then we allow children to consent for themselves as well. Also,
that's only for that certain age and above.
It's for 15 to 17-year-olds, and it has to be a treatment specific, one of those specific treatment areas. Sometimes it's in the best interest of the children not to seek parental permission or guardian permission. Perhaps if you're studying child abuse and you're wanting to work with the children, perhaps it's not in their safe enough environment to ask the parents' permission for those child, and you have to meet some requirements for that. Also, if you're involving wards of the state, there are special considerations there. And then if you're conducting research in schools, there are a number of laws that apply to research in schools. All right, so one of the questions that comes up a lot is, of course, about protecting confidentiality. A tool that we have in research environments is something called a certificate of confidentiality. And this is a legal tool that comes from the Department of Justice, and it protects data if perhaps you're conducting research that involves potentially stigmatizing information. And so you could think that it's perhaps information on substance abuse, sexual attitudes or practices, illegal behaviors, and we have a number of things in the list. It even can be employability, insurability. And so if you're working in a study that has, conducting a study that has these issues addressed, it may be in your best interest to seek a certificate of confidentiality, and these protect the research data and then subsequently the participants from compelled disclosure from a government entity. So if you are in a study and they're asking you to be honest about your drug addiction, then we protect those records so they can't be compelled in court. I have a whole list here of what an investigator's role is. I'll go through them very quickly. In fact, you know, they are to comply with the provisions and the requirements of the IRB. They have to be knowledgeable about human subjects protections. They need to follow the research as it's approved. So the way the IRB system works, it's a prospective system. You need to get permission from the IRB to conduct your research. And if you want to change your research, you need permission for that. They need to only do that which they're approved to do. They need to ensure that subjects understand the research before enrolling them. They need to keep their records appropriately and report information appropriately to the IRB. Additionally, if there's anything unanticipated that occurs in your study, that needs to be tracked and reported as well. So to your question, who's on these IRB? Who are these magical people? So it has to be at least 5 individuals to constitute an IRB. Our IRBs are a lot larger here because the requirement is that you have the adequate expertise and knowledge then to review the science that is proposed. And we have you know, medical school, nursing, dentistry, public health programs, all sorts of engineering programs. So we have a very wide background. One, we need to have, like I said, qualified faculty. We also have to have at least 1 community member when we have to have an individual who has no medical or scientific expertise. We want to have a balanced diversity on the board as well, and that's a requirement. Here they're appointed, but the IRB has the final authority to disapprove research. And this is really important because they may approve research and they may disapprove research, but nobody, if the IRB says no to a study, nobody here at OHSU can say, actually, this is a really important investigator. And we think that despite what you've said in your ethical review that this study should go on otherwise. That's not allowed. And people, we have, you have to recuse, have a person step out of the room if they have a conflict. So the IRB, I've told you their considerations. We look at the consent forms. We make sure all those requirements for review are met. And we look at their advertisements. If you're advertising, we look at, you know, their safety plan. If they have that, surveys, all their data collection tools, we look at all of those. And then once we feel like we've completed our rule, then we have to make our decision. And there's only a few things we can do. We can approve it as we see it. We think it's a great idea, which doesn't happen often. We can approve it with required changes. And there's 2 ways to do that. Either that it's, you know, there's minimal changes, and if you just fix some of these administrative changes, it's good to go. But if they're substantive changes, and those substantive means those issues that I covered in the list of required elements, you know, risk-benefit analysis, privacy and confidentiality, they're substantive, then the study goes back to the investigator. They have to answer those questions, and then the full board reviews their answers and then decides if they meet it. And then something can be disapproved if we really feel like there is no remedy that can make it fit within the guidelines for approval of human subject research.
How long does this process take?
We have 8 IRB meetings a month, 2 hours each. And so, you know, any study can go through pretty quickly if it's expedited in 2 weeks, or it could take, you know, 6 weeks or more, depending on if you have problems in your study. So I wanted to go over, that's kind of the basis and the background. I don't know if you have any questions about what I've discussed at this point.
Generally, how many studies are denied?
Not disapproved fully, not that many. It's not a common occurrence that someone has such a flawed idea that we send it home. Sometimes we'll say your application is so disorganized or messy that we think you really need to spend some more quality time with it. But otherwise, most of the initial studies are approved with some sort of change. And I'd say maybe about 30% of them get, at first pass, get deferred. It depends if there's another review group that's looked at it too. There's other groups that look at scientific quality, perhaps at the National Institutes of Health or through our Cancer Center has a scientific review board. But if it's a study and the IRB is the first group to ever see it, oftentimes there's a significant amount of work that's needed to bring it up to our standards.
What about studies that have been approved by other IRBs that also involve people from OHSU, and how do the two IRBs work together to not have to duplicate the effort?
Not always that well. So you're hitting on a point though where if it's conducted at multiple institutions, then everyone's IRB potentially has to look at it. We can set up agreements where one IRB can say that they agree to rely on the review of another IRB. And we are willing to do that oftentimes in minimal risk situations, less willing, of course, for greater than minimal risk. And I think that's a fairly common thing. But sometimes it has to go through two IRBs. Of course, everyone's trying to accommodate anything specific for local research context. So if it is that, that there are some things about your population that are specific that wouldn't be known by another IRB, then that's the most important thing to be bringing up for an individual IRB's review. But sometimes it's just a matter of opinion as to how to write a consent form. Other questions before I move on to the cases? Okay, I'm going to take you through a few quick cases. Hopefully I have enough time to go through these somewhat. They basically highlight, these are real cases. Some of them ended up as lawsuits, but they're real cases that have subsequently created ways that we enforce and form our protections. So the first one is a case of a young man named Jesse Gelsinger who was at research at the University of Pennsylvania. And so you asked, were research institutions really shut down? So this is one of the first cases that resulted in a shutdown. And this was a study of a young man who had OTC, and it was a viral vector study. What's important about this is that unfortunately he passed away and during the study, and it was felt that the family felt that they didn't have adequate consent. They had learned that the investigator had a significant financial interest in the trial. They had learned that there were some animal data that perhaps hadn't been incorporated into the consent process. And so this was to them the great harm. And in fact, one of the most significant outcomes of this is that we really nationally now have a system to accommodate conflicts of interest, to make sure that investigators are unbiased in their research, and if they have a financial interest, that we have a plan to manage that. Another, also a biomedical study at Johns Hopkins University, again resulting in a shutdown, and a shutdown being that the federal-wide assurance was limited or taken away by the federal government. But important to note that this means that all research at these are so significant that all research at these institutions must stop. And so she was a healthy volunteer in a study, and the investigator didn't have the appropriate permissions from the FDA to conduct the trial. She worked for him, so there were questions as to whether she was his research assistant, whether she felt like she could say no to being in the trial, and it was a bronchodilation study. They were bedside mixing drugs instead of using the pharmacy. And so all of these things resulted in a healthy volunteer dying. And this was really where we started to expand our concepts of who is vulnerable. Here this being someone who worked for the investigator and considering, did she really feel as if she could say no to being in the trial? This case is an interesting one because it's an environmental health study, and it's very difficult to study environmental elements because in order to study them, you can't alter them. They have to be present to study them. And so we have a center here for environmental and occupational research, and oftentimes, to look at how it is that pesticides affect children, you need to study children living and working around pesticides. So this was a lead paint abatement program in Baltimore, and the public health, in some ways similar to the Tuskegee trial, the public health program was setting out to decrease lead in the homes the older homes in Baltimore that had lead paint in them. But with limited resources, they were trying to figure out what's the best way to treat the biggest number of houses and affect the most children positively. And so they decided to try out, less, middle, and more abatement, knowing, in fact, that more worked. And they approached Kennedy Krieger Institute at Johns Hopkins to help them evaluate this. And this one's really important because some of the children in the study were found to have high levels of lead, which wasn't necessarily unexpected, and they were finding then, perhaps the lesser program doesn't work as well. But the participants were confused about how the research was being conducted. And they heard that Johns Hopkins was involved, and so they thought that perhaps these are medical doctors who wouldn't do anything that would be not in the best interest of the participants in the trial. And they were surprised to know that, in fact, they could still have high lead levels in the trial. And so it brought to attention how you separate out and accentuate the difference between what's being studied and what's not being studied, and expectations of performance. In fact, in the case of this, the judge in this case really said that there is a special duty of researchers to participants. It may not be the same as a provider has to a patient, but there is a duty here to think about the special needs of a research participant. The next one I think is really important because this talks about individuals' ability to control their own samples. And this was a collection of individuals in a prostate cancer registry. So they were holding samples from individuals being treated for prostate cancer. And the investigator was going from one institution to another and wanted to take his samples with them and ask permission of all the volunteers in the trial if we could do that. And most of them actually said yes. But in fact, this was an important distinction that it wasn't at that point the volunteers in this study or even the investigators' ability to decide where these samples went. In fact, they resided with the institution that funded the study. And this was a bit shocking to a lot of the people who volunteered because they thought that they could control their information and their samples as their property. But I think this is something that is little known, I think, in the general public, that when you give up your information in a healthcare setting and in a research setting, that then they rest with the institution. And I think there's a great opportunity for research in this area because we've got a couple of cases recently that kind of surround this issue, and I think there's a balance between public health and understanding ownership of samples. The next case is the Havasupai case in Arizona. This was a great case of participatory research at the start, where the population of Havasupai came to University of Arizona and Arizona State, and they said, we have a high incidence of diabetes in our population. Can you help us study this? And so they worked together to do this and then had a lot of samples. And they obtained consent from the participants, 400 members of the tribe, and had those for this study. They then shared samples beyond what was allowed in the consent form. And the samples went on to all sorts of studies, which were not things that the tribal population would have been okay with. One of them most significantly, they did some schizophrenia studies and various other studies, but the most significant to them actually was a study of origin of the population. And so while as I understand it, this tribal population believes that they sprang from the base of the Grand Canyon. In fact, this study suggested that they came over the Bering Strait, and this was very harmful to them as a community. And so I think what's important to come out of the Havasupai case is that it's just not individual harms. You have to think about community harms as well. And how is it that research in this population should be considered? The last two cases are similar to the Catalona case, and I wanted to bring them up. They're both similar, Bellino and Bearder cases, where it's using samples that were collected for public health purposes. So I know I was talking about the difference between research and public health. You know, when your children are born and they do a heel stick in the hospital and take a little bit of blood, and these are stored at the public health department. They're de-identified, so you can't tell who they are by the samples. But some research was being done in Minnesota and then also in Texas. And individuals learned of this research through various channels and really felt that this was not something that should be done. Now, legally and ethically, this is something that we can, as an IRB, approve. But at the population level, they felt that there was some sort of dignitary harm that you should have just asked. And so I highlight this because I think that, as I'd mentioned before with the Catalona case and the samples, I think we have a lot of opportunity for public education to understand the partnership with researchers and the value of research when conducted appropriately, but also understanding minimal risk and understanding the concepts of the conduct of research. So, you know, I think this is one that's a really good example of the work to be done in education about research. So that's the end of what I have prepared. I know we're short on time perhaps, but I want to make sure I answer any questions if you have them.
My only other question is, if you are wanting to prepare an IRB application, what does it entail?
So at any institution, an IRB application is going to have a series of questions that are helping us to gather enough information to answer all of our questions that we have. So you're going to have some sort of a protocol or research plan. If you're going to have a consent process, all the documents, be it consent forms, information sheets, advertisements that are part of that consent process. If you have surveys, perhaps your survey tools, your plan for monitoring data and information and safety. All of those will need to be submitted, along with typically filling out a form that helps answer all the questions that we need then to feel like we understand how you're recruiting, how you're protecting participants, things like that.
If you've never done this before, is there someone at the IRB that can give you some pointers?
At our IRB there is. So we do definitely have analysts and a number of IRB chairs that are all available to help accompany you through the process. If you're here at OHSU, we have classes that help train on that. And then again, we're always willing to train the trainer so that you can help your community partners do that as well.
You also, I know you had all these things listed for what's required in the consent form. You also have some documents that can help people, right?
Yes, definitely. We have template forms for you know, kind of a big consent, a minimal risk consent, and even an information sheet when you know that it's just sufficient to explain the study, but then you know, not necessarily have a requirement for signature. Because sometimes signature is not required because the only identifier for that this person has ever been in the study would be their pen to paper. So at that point, we'd say, you know, you might not want to have that signature because then that would identify them as being in the trial.
So you started with some historical incidents and then ended with case studies at the end, and some of them are fairly scary for a population to hear about. And so what can be done to help build the public trust in research when so much is probably done the right way, but those cases become, you know, the sentinels for change
Definitely.
that make it look worse than it maybe is overall?
Yeah, and I think what you said is important. That I think in modern times now that most research is done the right way, which is surprising, I think, to the community in some ways, where their greatest fears about their interaction with researchers and perhaps even the medical community may not necessarily be as real or as big as they fear.
Stranger.
But that being said, they're in every area there can be bad actors, and so you know, learning from those activities. In the 90s, when there were the big research shutdowns, we all kind of clenched up and got almost overly compliant, where the researchers out there would claim that we were getting too much information and too scared. And I think right now is a nice time in research oversight because we're looking at what it is as IRBs we do, and does it really achieve the goal that we're after, which is protecting participants in research. And so does all the paperwork mean anything? But to answer your question, I think the most important thing is public education. And I think there needs to be more education about research and the public's role in research. You know, we have community members on our IRBs. There are community advisory boards that inform IRBs, researchers, and so I think these are all really important parts of modern research. Great, well thank you very much. Thank you.